Well, good morning and welcome, everyone, and holiday greetings to all of you from the NCHICA Board. I want to welcome you to a December meeting of the National eHealth Collaborative Board of Directors. I am Dr. John Tooker, the chair of the board. We also appreciate those who are not here in person for participating online. For those of you able to join us here in person, printed copies of the agenda and presentation slides are available on the registration table. For those of you online, the packet can be downloaded from the NeHC website, which is www.nationalehealth.org. Before I begin, I'd like to thank our very capable staff, Brian Heckert, our interim executive director, Alex Baker, Merritt McGinley, and Ernest Clover for their work, and also all the members of the board for their continuing effort on behalf of our collaborative. As always, we welcome your suggestions and comments via the webinar or email to info@nationalehealth.org or to our staff monitoring Twitter #NeHIC. We ask that everyone participating online to submit your questions and comments for this morning's stakeholder forums in writing, but we will also have a public comment period at the end of this morning's session in which I will individually unmute phone lines for you to share any comments with us. If you would like to speak, please make sure you are logged into the webinar and have used the webinar-generated attendee ID when you called in on the phone. We are looking forward to everyone's participation in today's stakeholder forum, one of the trademark activities of the National eHealth Collaborative. So I will now call this session of the National eHealth Collaborative Board of Directors meeting to order. Before we begin, I would remind us all that NeHC has a conflict of interest policy, and we ask all of our directors and our federal liaisons to identify any real or potential conflicts to the chair of the board prior to the meeting, and to identify any potential conflicts during the meeting as well. I would now like to turn to our stakeholder forum. Today's forum is entitled Integrity, Authenticity, and Accuracy, Pillars for Effective Health Information Capture, Exchange, and Use. We are very pleased to have Dr. Arthur Davidson, a NeHC board member, and also the director of the Public Health Informatics and Preparedness for Denver Health. And I'm going to turn the panel over to Art, who will present our panelists, and we will have four panelists, and then we will have a question and answer period following the presentations from our panelists. Art?
Thank you, John. I'm pleased today to have the opportunity to chair or moderate the panel with the board members, and for those of you in the listening audience, either here or on the web. The panelists for today's session include Jack Davies, who's the director of the Northwest Telehealth Regional Outreach and Health at Work at the Inland Northwest Health Services. Holt Anderson, the Executive Director of the North Carolina Healthcare Information and Communications Alliance, NCHICA. Phil Renner, Assistant Vice President for Quality Measurement, National Committee for Quality Assurance, NCQA. And Jerry Hinckley, a practicing lawyer and partner and co-chair of the Health Information Technology and HIPAA practice at Davies, Wright, and Tremaine. I want to thank them, in particular, those who've traveled a long distance to come and visit with us today. I know how difficult that is sometimes. By way of introduction, I'd like to make a few opening comments. Let's see. Is this Merritt? Is that right? Yep. I just wanted to put up for us a way to begin the discussion with some definitions. These are definitions that I culled from a variety of sources, and I just wanted to put this out there for us to have a focus. Integrity is the way that we can assure that data are consistent, certified, and can be reconciled after any function that includes transforming storing, and/or sending data. That would include the history, the lineage, the characteristics and definitions, the metadata, as data are exchanged. Authenticity is the method by which we ascertain the data source and assure they are genuine and not counterfeit. And that would include some of the bits of integrity. So these are a little bit overlapping here, somewhat of confidentiality, and it guarantees the information's provenance. And that provenance needs to also be secure. That ensures that the authenticity and history cannot be rewritten. And lastly, accuracy. The closeness to the true value or degree of agreement of readings or calculated values. And that includes how a concept is measured or calculated by different methods and the level of agreement. So today we're going to focus on these three areas as the pillars for exchange. I had the pleasure just 2 weeks ago of having my physician call me back for a routine blood test that was ordered in his EMR, sent to the laboratory, and then processed under another name. And my physician called me back to repeat the tests, and only because the other person was billed for the test did I find out that it was processed in someone else's name. This is not something uncommon, and most of us at some point in our lives will probably be subject to this issue of integrity, authenticity, and accuracy. On another note, in terms of my personal experience, let's see. Oh, need to go one more forward? There. I just wanted to make a few comments about the experience from Colorado and how in establishing the Colorado Regional Health Information Organization, we have dealt with some of these issues. I think the opportunity to exchange information is highly predicated on your ability to demonstrate this trust and assurance that there is integrity, accuracy, and authenticity to the data. And to do that, we spent a fair amount of time developing policies that are now being put in place for the next phase of COREO, and we built on those policies. So it's important to think about the structure and governance, including the policies for operations. We spent an enormous effort on building a federated index, master patient index, across 4 major partners with 2.5 million records for registrations, which equaled about 1.4 million individuals. Not a small task, and not all the software out there is highly tuned to make this happen with a lot of ease. This is a big issue, and just as I described for myself with my physician, identity is not easily managed across multiple institutions. But even within institutions, there are issues. There are issues around how you deal with twins. And in certain cultures, the way that you write the name may be varied, first and last name may be represented twice in some cultures. So we had quite a bit of effort put into this building the EMPI in Colorado. The algorithm, however, after it was built, created a lot of value to the healthcare organizations that were part of COREO and continue to be part of COREO. The information that we were able to give them back helped improve the quality of their internal data. And then by doing so, they could prevent propagating errors throughout the rest of the exchange in COREO. So that was just by way of introduction of just hoping to kind of set the stage here for a few of the issues that we experienced in Colorado and how we were able to leverage the experience to date toward now our next phase of finding additional vendors to support the statewide effort across all of Colorado. So with that as an introduction, I'd like to now invite Jack Davies to start off our discussion, and we'll go through the 4 speakers unless there are some clarifying questions, and then have a more full discussion at the end of the 4 speakers. So with that, Jack, please. Yes. Would you pass it along, please? Thank you.
Thank you, Dr. Davidson, and thank you to the National eHealth Collaborative for the opportunity to speak with you this morning. I'm going to be, hopefully, thank you, starting with sort of the beginning of the chain, the beginning of the process, the accuracy of information that is gathered at the point of care, at the original encounter with the patient. Yes, but can I do it on there? Thank you. Okay. Sorry, I have driving issues here. The point of encounter, when we talk about the three pillars that Dr. Davidson outlined, integrity, authenticity, and accuracy, really the foundation of all of these is how the information is gathered at the first encounter. If you don't have accurate information at that point, then the entire chain is going to be disrupted. You're not going to have the ability to make good clinical decisions. You're not going to have effective health information exchange, and it's really going to disrupt the entire continuum of care. I'll get these arrows figured out at some point. Let me just talk a little bit about our organization, and then I'm going to go into some experiences that we have had that demonstrate why it's so critical and why it can be so difficult for information to be captured accurately at the point of care, particularly involving electronic medical record systems. At Inland Northwest Health Services, we're an organization in Spokane, Washington, that provides shared services to a variety of healthcare organizations, physician offices, hospitals, clinics, and so forth. We do health information technology and exchange, telemedicine, a very large network in the region. We also operate an inpatient rehabilitation hospital, an emergency air transportation service, and a variety of community health programs. A large portion of our health information technology activities in the area of electronic medical records, both on the hospital information system side, which we've been doing for about 15 years now, 14 years, and also on the physician office side, which we've been doing for about 6 years. On the EMR side, we provide both consultation and implementation services, and we also provide support for application service, centralized application service provider type model over time. And partly because of our efforts, we have a very high rate of EMR adoption in the community. What we've learned through this is that there really is a fundamental balancing act when you're talking about EMR implementation and operation. On the one hand, you want to be promoting standardization to support interoperability, to support increased quality of the information that you're gathering. On the other hand, you've got efficiency of operation. You've got how easy is it for the provider to enter information, how easy is it for them to really feel like they have real clinical control. And I have a quote on here from a physician that's been using an EMR for a very long time. And he said, "We try to standardize data entry, but in doing so, we end up frustrating and slowing down the physician so that then we have to loosen up our standards. And when we run reports, physicians get upset that their data is not accurate. So it's a no-win situation." Our particular example where we have been learning about the perils and pitfalls, so to speak, of EMR utilization is a project we've been working on over this past year around personal health records. The project's called One Health Record, where we are actually importing data out of, or exporting data from the physician office electronic medical record systems to a patient's Google Health account when they request that. It's advanced. Holt, you're messing me up here. Oh, well, okay. The personal health record project is something that, as I said, we started about a year ago, and it's a new project where we have set up with 3 participating clinics. They're each independent offices. They're all using the same electronic medical record project. We've established a health record bank hub that manages the access controls to the system, takes care of authentication, and actually provides the linkages to those electronic medical record systems. Currently, we're limiting the project to medications and allergies for reasons that I'll go into in a moment. It's been functional since about March. We have a reasonable patient participation, and so we've learned quite a lot in a short period of time.